Okay. And I usually talk right through, then I catch up in the slide. Okay,
Okay.
thank you so much.
Yep.
Okay, good mornings and welcome to the sixth session of Life in the Forest. Our speaker today is going to be Leanne Bailey Clayton, who's Director of Health Services. Leanne, please, thank you.
Thank you, Ms. Smith, and thank you so much for having me today. Just to make you aware, we are recording this on Zoom. There are a number of people that are away that would like to have had this information. So I appreciate Emma and her team making this possible for us to do. So you won't have to do anything different. What I'll try to pay attention to is repeating your question so that when that is answered, that will flow for folks that are watching this at a later time. I'm Leanne Bailey Clayton. I've been at the Forest since 1999. That's 26 years. In September will be 26 years. And I've been in this or the acute care industry for 36 years. Probably the significant thing is I had an opportunity to be a social worker here for 16 years. Then I was an assistant administrator for 2 years, and I had the opportunity to do my administrator and training here at the Forest because the Forest is very much in support of promoting from within. And now I've been in this role, Christopher Lockmer, you're not gonna believe this. It's been 8 years now. December will be 8 years. So that's interesting. I've never thought of doing this part, but it just seemed to happen naturally. So who in the room has been here less than 6 months? Okay, all right. And everyone else has been here more than 6 months because I recognize everybody. Okay, so what I want to do is share with you information regarding our clinic services, our physician services, and how the continuity of care happens where that is concerned. I will also be doing Karen's presentation. She's away. She and I do this presentation together. I might not know every single answer that you would ask her where the finances are concerned, but I know a large majority. Oh gosh. I know a large majority of that information because it's applicable to your coverage of services here at the Forest. So the team members and the providers in the clinic are the clinic nurse. Oh, I'm sorry, this hasn't been updated. Karen Heath is our nurse clinic manager. She has 25 plus years of experience as an RN. She's been with us right at a year now. Laurie Locke is our clinic administrative manager, and she's been at the Forest. She started before the Forest opened. Laurie did. So she's been here 4 and a half years.
34 is a long time.
Yeah, like 34 years. Laurie is a vital part of information sharing that happens in the clinic. She is that point person. If you're a new resident here and you've decided that you want to acquaint yourself with the clinic and maybe you're going to, change your doctor or something like that, if that's something that interests you, then Laurie is that person that you work with. Laurie is the person that works with you about getting an appointment, whether it be here or at a specialist. That can be quite a chore in the Duke system to get an appointment with someone that you need. So Laurie is the pivotal character that helps that happen as well. She helps if you want to have pharmacy delivery. She is the person that takes care of all of those things. There's not much that you can't find out from Laurie that you need. It's really a one-stop shopping, whether that's about the clinic and the providers, or if that's just about the Forest in general. So we're really proud that she is with us. Our providers are Dr. Milta Little. She is our medical director, and she is a geriatric primary care. Dr. Gwendolyn Boer is our clinic director and is also a geriatric primary care. Dr. Boer has been here, let's see, she had both of her kids when she was here, about 17 years. 17, 18 years. Dr. Liza now, she is also a geriatrician and an MD, and she is the part of their team that when somebody's on vacation or at a conference, that type of thing, she does filling in. But she did her fellowship here, so she has been very familiar with the forest for a long time. And then Holly Winger, she is our nurse practitioner. I would say that if I had to choose one of these roles that has been incredibly pivotal to creating seamless care from independent living to the health center. Holly is so much that person because she is here 4 days a week. She is not here on Thursdays, but she is the person that rounds in the health center every single day. And she's so much a part of that continuity that she is able to bring things forward where you are concerned. Even if you've come in for an urgent care visit at the clinic, oftentimes that's who you will see as Holly Winger. And she's a, yes, ma'am.
What's the difference between medical director and clinical director?
So the difference is the medical director is required by all of our regulatory bodies and everyone that has jurisdiction over us because Dr. Little has the last say in a medical issue. If there is a, what's the right word?
Pandemic?
Huh?
Pandemic?
That, yes, pandemic. She was my partner during the pandemic for sure. So if there's and so she is responsible for all of that overarching decision making and intervention for the entire forest at Duke. And Dr. Boer is more concentrated specifically in the clinic. So that just keeps that. So we have all the expertise we need in all the different
And I
spaces.
just want to slip in, Holly Winger is now my primary.
Yes,
She's amazing.
she is amazing.
She's really been helped.
Yeah, she's great.
Thank you.
Okay, so are we gonna do questions throughout? Or are we gonna wait to the end?
I just, the pending candidate, it's not Karen. Karen's not pending candidate. We are.
Yeah, it's Karen. Karen.
No, I
Heath.
didn't.
Uh-huh,
Oh,
Karen Heath.
okay.
Yeah.
Okay.
They just hadn't been updated. I didn't realize it was still there.
She is very.
Yeah, Karen Heath. Yes, exactly. Yes. No, we can talk any way y'all want to. It doesn't matter to me. But yes, that's the distinction between those two. Thank you for that question. Okay. So the history and a little bit of what the present is like for the clinic. The forest at Duke has been associated with the Duke University Division of Geriatrics since we opened our doors. Okay. We have we worked with one of the original physicians. His last name starts with an S. See, I mean, I'm getting off to Sutherland, I think. He helped us open the forest in terms of that medical piece of it that needed to occur. And then Dr. Tony Galanis came on board and stayed with us for probably 15 or 20 years. And we have been blessed to have our team members and our providers always immerse themselves, excuse me, always immerse themselves in our policies, our procedures, our practices, our operations, and they are very much a part of our active team. They're not a doctor that's on a phone somewhere that I can't get in touch with. They're not, I mean, I've heard Dr. Little's children grow up, because I talk to her and they're in the background. They're part of our relationship. They're part of the relationship with you. They're part of the relationship with us. And that is very special because that is hard in today's climate with so many nursing facilities out there, particularly that have a doctor that comes by once a month. If they can get that done. So we feel very blessed about this. I like to play the game in situations like this of answering the questions that I know you have before you ask me. That's the game I like to play. So are we going to have enough physician services when the folks from the terraces come? Okay. So the answer to that is yes. Karen, Anita, and I have been have actively participated with the administration with the Duke Center for Geriatrics at Duke for the last, we met 2 years ago, and then we just recently met again. So we went ahead and put those necessary enhancements and expectations on the table and said, you know, we want this service done in this very specific way. And we don't want anything to change in terms of service for the people that live here now. And the people that are coming, 80% of them are from the Raleigh Durham Chapel Hill area. And unless they're in one of the practices where every single doctor in the practice is retiring, because you know there's a whole group of that happening, they're going to have their own doctors. Very, very seldom will we see that initially. We normally, the data says that after someone's here 3 to 5 years, or if they have an acute episode while they first move in here, typically they will stay with their own doctor. We have 10% coming from another part of the other parts of North Carolina, and then we have 10% that are coming from out of state. Those would be the people that would more highly impact needing primary care, but we have already budgeted and put in place the hours that are needed to make that happen. So I have no concern about that whatsoever. Yes, ma'am.
I'm new here,
Yes,
4 months,
Mhm.
and I lived in Chapel Hill for 15 years.
Mhm.
All my doctors are UNC,
Uh-huh.
and my chart is a UNC
Uh-huh.
here.
Uh-huh.
But I was told that that gets shared, that can be shared with Duke, with a Duke, my chart, is that
Right.
right?
So
And should I switch to a doctor in like Polly here?
So that is 100% a personal question. I mean, a personal choice.
Um,
100%. But so what has happened is it's called Care Everywhere. UNC and Duke, we can talk to each other over the medical records now.
mhm.
We can see your medical record. If you say, hey, you know, I went to the hospital, I was at UNC, you know, I want you to do this. And then we have to say, oh, yes, we acknowledge that you asked for us to look at your medical record. We can't just go, you know, cruising around.
If I have some crisis here, I mean, some, not major, but
Mhm.
is it useful to have a primary care doctor here?
Well, I mean, so our process is, and I'll talk about respond a little more in a minute, but I'll go ahead and speak of it now. So if you have a respond call, do you have everything? Yeah. See, aren't you good? I'm not gonna ask y'all. That's dependent on. If you push your pendant and our nurse comes to see you, we will call your primary first. If we do not get a response basically immediately, that we're going to hear back in, you know, the next 10 minutes from someone, we call our on-call doctor. So part of the service we provide is we have on-call physicians 24/7, 365. So we can make that response situation happen. So that is strictly up to you because our service is not going to stop for you in an emergency or even a minor emergency, if you need care from us. You are part of the forest. You have signed up to have these services, and that's what you will have here. And then our doctor will send a note to the primary care to say, this is what happened. This is what we did. I understand she's coming to have an appointment with you. Okay, so the communication is fluid.
Okay.
And so that really makes it a super personal choice for you because there's not going to be an interruption in service for you or response in any way. Okay. All right. So as we just spoke about this, so as we're part of the Community Connect with Duke, and we became part of the Epic system, the Duke MyChart system, probably 10 years ago now. And that is where our physicians chart for you when you go to the clinic. What they chart for you if you were in the health center there. We also have what is called point click care, which is the electronic medical record for skilled nursing and assisted living. Unfortunately, Epic didn't have a program. I said, could y'all please get one? They said, we're not going to do that. I said, okay. So we had to get something else. And in doing that, we have been able to import and export things as we've needed to make communication as fluid as possible. Okay. I just want to make a note about urgent care. I think your comment was important. So let's just say you cut your hand, okay? And you walk to the clinic and say, I cut my hand, you know, I need some help. So Karen's going to see you, or Holly's going to see you, or whoever the doctor's in that day is going to see you. And we are happy to help you and support that way. You'll never be turned away because of who your doctor is. Okay. So that's just really important to know that. We do have physicians here 5 half days a week, Monday through Friday. They are on call 24/7. We have a rotation for that. And Holly is in the clinic Monday, Tuesday, Wednesday, and Friday. She's off on Thursdays. Okay. Our services that are provided in the clinic by the providers are your annual wellness visits, acute illness, urgent care, prescription management, health education, specialist referral, same day and next day appointments in the clinic, Medicare filing for your appointments, and any necessary labs. So let's just say that you are someone that has to go to the Coumadin Clinic at Duke. Okay. You have to go to the Coumadin Clinic at Duke, and just navigating that can be somewhat of a challenge. If you choose to have your blood drawn here, we are connected with and affiliated with the Duke Lab. So we can certainly draw your pro times here, get the information to the Coumadin Clinic or to your physician, and that comes out of Duke Lab. So everyone's able to see that as they need to readily see that for you. So if there are conveniences that can occur, that doesn't mean you've changed your doctor. That means you're just using some of the service of convenience. Okay,
And if I'm at UNC,
I'm sorry.
if my doctors are at UNC, you talked about Duke, communicating with Duke.
Right. Well, then what we would have to do is we would get the lab results and then we would have to either call that in or scan that in to them. Yes, one or the other. Yeah. We're not affiliated with UNC lab. So I'm just talking about Medicare filing, and I'm probably talking about the next slide at this point, which is I often do that and I apologize. But Medicare filing means that we're going to put an ICD-10 code and we're going to file your visit with Medicare, and you will have a copay that you're responsible for. Okay. So what happens over the course of that time is you will have a copay. And that might not seem like something that you're happy about or whatever the case may be, but if you go to any Duke clinic, you're going to pay a copay. But what that does is that moves you toward the needle towards you meeting your deductible for the year is what happens with that. So you will see that as well. Okay.
If I have Medicare and I've got a supplemental insurance plan that pays my 20%, would you all file that as well?
So we're going to file whatever insurance that you have, and then Kasia will move it forward if it has to be moved forward to the secondary insurance. Specialists that available that we have on campus is we have two different providers for audiology. We have Duke Audiology, and who knows the name of the other one?
Hearing health.
Hearing Health. Thank you. They change their name about every 6 months. So I can't keep up with what their name is. Hearing Health, they've been with us many, many years. We have podiatry service available. We actually have a podiatry specialty nurse. We've never had one of those before. Her name's Jennifer. She is phenomenal. Isn't she? She's very good. She actually reached out to us, and our podiatrist had just retired because we weren't sure what we were going to do. And she's really good. And I love that she knows exactly where her expertise ends and where the podiatrist expertise needs to become involved. When you're using someone that's not the podiatrist, the doctor proper, you have to say, oh, I hope this is going to work right. It's phenomenal. I mean, she'll stop way ahead of where she needs to be to make sure somebody has the right referral. So I've been very happy with Jennifer's service. I'm glad to hear you have too. Psychiatry, we do work with, what is wrong with me and the names today?
Right?
Oh, psychiatry, I can't remember, right? I think they just changed their name to CASA or something like that. But anyway, we have psychiatry care here at the Forest. They have talk therapy that's available. That would be the more popular thing that is needed in independent living. As far as the health center is concerned, we are not allowed to have anyone on any type of antipsychotic medications without the input of a psychiatrist. And they're required tapering for those types of medicines and monitoring. We are involved with a very good group, and actually Sandy from Carolina Meadows told us about them because our person retired. So I'm very excited they're a part of our team. Dentistry, we do have mobile dentistry that goes into the health center and takes care of those folks there, so they do not have to venture out. But that same dental group, Studio G, is also going to be the folks that are going to be working in our dental suite in the clinic when it opens. And they were the people that were here before in the old clinic. So I understand they've been very supportive in this time during construction. If someone has needed to go to the dentist or had an urgent matter, we could certainly take them, or they could go to the brick and mortar in Chapel Hill. And they have been very helpful with that. Ophthalmology, Dr. Newman is our ophthalmologist. If you have needs, please know he's on Irwin Road. If you needed an ophthalmologist and you did not have one in the area, he is happy to take you as a Forest resident there. But he does come once a quarter, basically, unless our list grows sooner than that. And then he will come and do ophthalmology work here at the Forest as well. And then dietary, we have a registered dietitian here, Shannon O'Coin. She is available and certainly willing to do any dietary consultation with you that you may want. Okay. Pharmacy services. So there are several local pharmacies that that do deliver to the Forest. That became really popular during COVID, and a lot of people just didn't go back because it became so convenient. Pharmacy is something to navigate. I'll tell you, I did it for all of my parents, and it's a thing. But Laurie can help you with getting prescriptions sent in. You know, if you have an appointment and Dr. Brewer has changed something for you, we can send it to your pharmacy, no matter whether it's one of the ones that delivers here or not. She can help you with that. But speak with Laurie if you would like to participate in any of the delivery services, but she can help you navigate that in any way you need. They also have the derm pharmacy particularly has the ability, if it's becoming complicated to, well, so let's try opening the bottle. That's complicated. It's not childproof, it's adult proof, you know, the lids, and pouring them out. I mean, all of this becomes a thing over time. So they have the ability to do the punch cards. They have the ability to do some pouches for things and different things to help you feel comfortable in managing those things if, you know, that's changing for you. Okay. And that's just normal. Billing. So your visits to the clinic are filed to your Medicare provider. The copay responsibility will be the residents. Any dollars spent toward copays with the Medicare system are directly applied to your annual deductible. I told you I skipped ahead and don't realize it. Sorry. Transitioning through the continuum. One of the most important things about transitioning at the Forest is the continuity of care. So there are two very specific services that we want to make you aware that are helpful to have from beginning to moving to the health center. So we have two social workers. We have Jennifer King, who's responsible for the alphabet A through K, and that's based on your last name. And then Carissa Campbell is L through Z. If you have a different name from your spouse that's a last name, then you guys talk and decide which one of them it's gonna, if you're in two different alphabets, how that's gonna go. So often something will be going on with one person or the other, and that's how it gets sorted out. They are with you from when you move into the Forest to you move to the health center, even through end of life care. Okay, it's the same social worker. There are very few circumstances where that is not the case. I can't think of one right this second. But this is a crucial part of being able to work with the same person who begins to learn your family, learn your routine, learn your dog, learn all of these things about you, so that in fact, when the time comes that you need to transition, then you guys have been talking about this for a while. You know, you've been saying, well, you know, if I can't do, you know, get up by myself from the bed in the morning and I can't do these three things, then I'm going to have some more support. So it becomes more of a natural process. Are there emergencies and people have to go to the health center? There are. Okay. Are there things that happen when people have some, mild cognitive or moderate cognitive impairment? Are there situations that occur, or a daughter doesn't live locally anymore, or their support system changes in some way that it becomes more of an urgent situation? Yes, that happens too. So I'll go ahead and say this because this is funny. We do not dress in black and under the cover of darkness come and, take people out of their cottages, villas, otherwise residents, and fly them away on the magic carpet or the golf cart and take them to the health center because the census is low. We don't do that. I'm asleep, they're asleep. We hope you're asleep. Okay, so, that's been said before, so I, by no means being snarky. Folks have had, it's been hard for someone to understand. Let's just say Ms. Mockmore had something happen overnight. You don't mind if I use you, do you? Crystal? So something happens with Crystal overnight and she's supposed to respond to it and she comes to the health center. And the next day, her two neighbors don't see her. And that's concerning them because y'all look out for each other. That's part of what being in community is about. But you can't jump to the natural assumption that we stole her away. We're helping her in some way. Or she's, needed to go to the hospital or something like that. So, the social workers and I, we kind of joke about that so that people can also have the opportunity to know that support that you need is here, that net that you need is here. But we also are not preemptively having people move from independent living to the health center. Yes, ma'am.
When the terrace is open, is there gonna be a third social worker?
Yes, ma'am. Oh, man, you beat me in my game. How are we gonna tell that?
So how are you gonna do the alphabet? They're just gonna be their person and we're still gonna be A through K and.
No, so the way that will work, and I've written the plan and I'm talking about it in my budget proposal this week. So if Anita says that's not exactly how it's gonna work, please don't get me in trouble. But this is my understanding of how it's gonna work. There's an implied idea that some of the terrace residents are still working, some of them are a bit younger, not under our required age or anything like that. But there's a splattering of ages, among the folks that are moving in. And they would have, unless they were having an elective surgery or something like that, potentially less acute needs. So in my mind, the third social worker will be working with the terrace residents up front. I need to come. I'm going to come and meet you and do the meet and greet, tell you about the services here. And if you have a question, please let me know. If I fall and break my hip, then Jennifer and Carissa will also be assigned to, with a new social worker trying to learn everything. They will be assigned to each one of the terraces folks as well, based on their alphabet. And then they will work with that new social worker to go through the process with whatever that person needs. So I feel like that's a partnership. I've written that program. I should find out on Thursday if that's the way it's gonna go. But that's what that thinking is. And just getting to know the forest is its own challenge, so.
How many residents can one social worker effectively handle? I mean, if that's a.
Yeah, so I think the important thing to know is if you have in this environment, because I was the social worker here for a very long time. So if you are working specifically in the health center, so my coverage was the health center when I was a social worker, and we had a separate independent living social worker. So the work that I'm responsible for there has a lot of regulatory involvement in it, timing of different things that have to be done and all of those types of things. So that becomes very specific because the most residents I could have would be 92 at that time. But the health center's never been full. It's never had complete total occupancy. So that was certainly very manageable. However, I've managed both sides at one time. The folks in independent living are living their lives, and it's as you need something, that social worker is going to help you if you need something. Like, for instance, you got to know your social worker very early on because you had something specific that needed to happen. And right. And you may not, other than just, friendly exchange, need your social worker again for 10 years. So it's very manageable. It's not a number.
Sure.
It's the fact that they are working on the exception. What is the exception? What is it specifically you need? And that's how that goes. And, there are a number of people that aren't even here all summer long. Are there somewhere else? So it's not based on a number. It's based on working with need.
Yeah.
Mm-hmm. Yes, sir. Oh, absolutely. So let me go ahead and answer some of the other questions in advance. So, will we have, with the post and the terrace moving in, will we have enough space in the health center for everyone? Well, we have never in my 26 years here had full occupancy in the health center. Because nature has its own rolling way of doing things in threes. That certainly happen. Our team is great at utilization, at bed utilization. We're very good at that. And we are very preemptive on when someone needs to be, you know, not in assisted living any longer, needs to be in skilled nursing. So I have no concern about that whatsoever. And I would be the first one to say that. We also have the Forest at Home. The Forest at Home is not a level of care. It is not meant to extend someone's time in independent living if they are in an unsafe situation. It is support that allows that person to continue to be in independent living without the risk. Okay, so it may be medication management. It may be going to the grocery store. It may mean that daughter doesn't work here in, live here in town anymore. And so, I need some help going to doctor's appointments. You can be supported in that way and remain independent living a long time. That never trumps safety. That never trumps dignity. That will never trump those very specific things. Okay, so I thought I would answer that one. Yes to the social worker. In my program, that goes to budget on Thursday, is an additional respond nurse that would work overnight. Because anytime on nights, holidays, or weekends that a respond nurse comes to you, they've left the health center and they've come to you. So they've left someone that they're responsible for and taking care of, and they've come to you. We make that adjustment in the health center while that person's gone on that respond call. But at the same time, your four nurses have turned into 3. Okay, so it's an important communication factor that happens, and it's worked well. We've not had any trouble with that. But if you want to strive for that premium care and comfort and security of knowing what's there, I'm asking for an additional respond nurse to work from 11 p to 7 a. And that person would be the first responder, not to use that term inappropriately, but be the first response. And then should there be a second call, and that happens more than then the nurse from the health center would come. Okay, so we would be taking care of both of those.
Is your goal also for faster responses, especially,
Faster than what?
sorry,
Faster than what?
that's the whole question, is 4 minutes or is it 20 minutes? I mean,
So we do a report and there's an average, and the average time for any call response is, I think it's at 12 minutes now.
Yeah.
It had been 10 for ages.
sure.
But if you have someone and I'm caring for you, and I'm the nurse and I'm also the respond nurse, I'm going to wrap up what I'm doing with you. Make sure somebody's finishing it if it needs to be done, or I'm going to finish it if I can. Okay, and I'm going to gather the respond bag and I'm making my way to you. Well, you're in an emergency and that feels like hours.
Oh,
But I'm getting there as quickly as I can, and that hasn't stopped since I got the call. But I mean, it by the time that all happens, it may be 20 minutes.
there's been an issue in the past about transportation for that nurse to get to an independent living cottage or apartment. That been resolved?
So we have a vehicle that's left for us by security.
Okay, they can drive it themselves?
There's a key that waits for them at the front desk, and they are able to drive that. From time to time, I do have to call and say, "There's this," and they'll bring it over. But once, the major transportation medical appointments are done for the day,
Sure.
then that vehicle is brought over for the nurses. And I will tell you, I mean, let's be honest, the big challenge is someone new here navigating this campus. It's not easy. It's not easy. So there is some more concerted effort being made in how that training happens. To say you gave somebody a map and they should follow that, if you gave me a map, I would never find you. I'm gonna travel because you're gonna tell me the green buildings over there and go to the right. I mean, I'm a landmark traveler.
Yeah.
So that is something that, we are making a concerted effort. And often, so not often, security makes a first contact with that resident that has pushed their pendant.
So they're there to help.
Well, a couple of things happen. They'll say, oh, Miss Jones, can you tell me a little bit about what's going on? Well, I've gotten my foot stuck and I can't get my shoe. Okay, they're gonna go pick up the responders and bring them to them. If that person says I'm having chest pain, they're going directly there. Okay, and if they're having chest pain and the nurse gets that information, our protocol is we call 911 before we even get there. Yes, ma'am.
Thank you.
I was told that you don't have AEDs on campus, don't use them here.
We do not have it.
So if someone is having a heart attack, does security do anything, or they wait that 20 minutes the nurse gets there, or waiting till 911 gets there?
Well, our security is not going to intervene in someone having a cardiac event, other than to make them comfortable. But the nurse will be on the way, but they will call 911 on the way. And no, we do not have a EDs on campus, and that is in conversation at leadership at this point.
Where the nurse would do CPR until the 911 got there?
Unless you have your yellow form with you and say, don't do this to me, don't do this to me. If you're in your apartment, that's different. You have your do not resuscitate on your refrigerator, on the back of your door, wherever it is. If that's there, that's a physician's order and we would not begin CPR. If you were alert and you said, do CPR on me, we're gonna do what you said.
One question about, I have primary care doctor, I have specialists that treat various health issues, and I'm very happy with them. But if I get a common cold, can I come and see someone in the clinic? And if I want to do that in the future, should I go into the clinic and become acquainted with someone there before I need it?
Well, so urgent care is available at the clinic. A cold would certainly qualify for that. And you could go in and see Laurie and say, I would like to see someone. I have this cold, and we'll make an arrangement for you to be seen.
But I don't need to go and introduce myself.
No, we already have your name, where you live, your phone number. We know a lot about you if we haven't met you.
Okay.
Okay, all right. Any more questions where that's concerned? Let's see, I answered, are there enough health center beds? I answered, is it gonna be a responders? I answered if there's gonna be a social worker. The clinic will be moving to its new space. I've been into the new space one time, on a required tour. The new clinic is very nice. The dental suite is there as well. I think you'll be well.
How far is it to walk
From where?
from here to the new health center?
Well, it's
In the hall.
it is identical to where it was before. When they tore that down, they put it right back in that same spot.
Yeah.
It sure is. Well, I have to tell you though, the connectors and, the skywalk, everyone said, oh, we'll never be able to walk that far, to the clinic. And the skywalk made that really cool way to do that. These, the way these bridges are and the way the corridor on level 2 is built in the new building, it's very vast in terms of ceiling and width, but it's a quick walk. I was very surprised by that. I thought it would be a little more.
Will they be controlled entry and all?
The health club, I like that. I like that name better. Yeah.
When you come out of the connector into the health center, it'll be controlled entry.
And we will have reception there as well. That's also where we're looking for that respond nurse to be stationed from 11 to 7 as well. So yes, we'll be covering that reception desk there on level 2. And then there will be times just like our elevators and all of our other entries. After 8 o'clock, you have to use the fob to get it. Okay. So I think I answered all those what if things where that was concerned. Okay, Emma. My husband calls me nickname blue screen of death, so I don't want to mess up your stuff. Was that helpful information?
Yes.
Okay. So, why is this topic important? Okay, I didn't know how hers was set up. So what is the first thing you're asked when you go to the doctor's office?
Insurance.
Mhm.
It's on lately.
Right, have you been out of the country? Have you fallen? And can I have your insurance card?
You
Okay,
have to remember your birthday too.
that's right, that's right. It's all very complicated. So current insurance coverage is very essential to your provider. Because insurance, once you go and you've received your service, I feel I have this cartoon in my head that insurance coverage and where it needs to go is on the back of a turtle. And it goes like this. You would never know it was all electronic because it all moves very slowly. So you want to have your most current card. Most companies, most organizations issue a new card the first of the year. Hopefully you have it by January 1st. That's always their goal. But if you have the wrong card or it's out of date, that turtle becomes paralyzed and he goes backwards, and they don't go backwards very well. And then he goes like this again. So you may get your EOB in 10 months and you went to the doctor in January. Okay, so you want to keep up with what that looks like. Where am I with my deductible? What was I charged for this? You know, everybody has a different way in which they keep up with that type of information, or if they care about it at all. So just know that that's really, really important. Okay. Please let accounting know right away if your insurance changes. If you get a new card in January and it has a different effective date on it, or it has a different number on it, or a different letter character for any reason, please get that information to Kasia. Kasia keeps that information loaded in our global system so that if you come to the health center, Mary Lisa is going to copy your current card so that therapy has it, so that the x-ray people have it. So everybody that needs it, that we need to build something for you while you're in the health center, has your right card, or the turtle starts going back. Okay. Key facts. The Forest at Duke participates in Medicare A and Medicare B. Medicare does have in-network or out-of-network benefits, and seniors can see who they want to choose. They can look at that. The Forest at Duke is not in any insurance company's network. Our skilled nursing facility is closed and applies to the Medicare Advantage program. So what does all that mean to you? I'm going to take this in two pieces. What does the certificate of need closed for skilled care mean? What that means is you all invested in your the community of choice, the Forest at Duke, and you have bought basically a life insurance policy. Okay, for any level of care you're going to need while you're here. Okay, Medicare Advantage plans. Okay, they want the health center to have 25 beds so they can negotiate with us what the cost is going to be and what we're going to charge them. Well, we don't have 25 beds. I can't say we'll ever have 25 beds. We have 4 beds, 4 Medicare beds. So the Advantage plans will not work with us on being in network. It's not that we haven't tried. They won't. It is not worth their time or money for us to do that. Okay. What does that mean? When you come to the health center, if you have traditional Medicare, okay, then our team has a responsibility to follow a specific track with Medicare in which we are making sure you are meeting therapy goals, that your nursing needs are being documented as they need to, because that's what Medicare weighs in terms of what they're reimbursing for your care. So we get one lump sum payment based on a form called a minimum data set that we send in for your care. Your hip may have been $10,000 and your hip may have been $25,000 based on what you need. So that says to me, I already know you must have had an infection. There was a problem with your wound. There was a need for IV antibiotics. So all of a sudden, I know in my head, because I've done it so long, the 15,000 differentiation is that yours was a complex hip. Okay, so that's how that works. That's traditional Medicare. We move through that. We make you aware when you're plateauing and when Medicare's not going to cover that any longer. Okay? The Medicare Advantage plans tell us what to do. Okay? So when you leave the hospital, you're required to have by your case manager a provider number, an approved, a prior approval to come to the forest. And they tell us that day, we're giving you 7 days. Okay? And so on day 5.5 or 6, we have to send in all this paperwork to them for them to decide if they're going to continue to cover you or not. If they choose not to do that, then you have to appeal. Now, while you're appealing, you're remaining in that bed and you're getting the service that you need. That doesn't change for you at all. This is a business phenomenon that's going on while you're there. But you're very much at the center of that because you're their customer and they want to talk to you that you want to appeal. We can't appeal for you. You have to do it or your designated family. Okay?
You're still talking about Medicare Advantage.
I am. Okay, so then they may say, okay, well, we're gonna give 4 more days. We go back to the table again and send them all the things they need. They tell us, but this goes on and on like this throughout. It's a bit stressful for the resident. And we know what our part is and all of that, and we do that. But we're coming back to you constantly saying, so they've given 4 more days, you know. Residents have said to me it's stressful. I know it's a stressful process. That's why I say it.
I have a Medicare Advantage plan. I've been over to Duke and got a new knee and they said, you need to come over and spend about 3 nights. I'm gonna use 3 of my 15 days. How does that fit into what I might or might not be charged for those 3 nights?
So if you have a 3-night qualifying stay in the hospital and your Medicare Advantage program has given an authorization number for you to come, then you come to a Medicare bed. You don't have to use your prepaid days at that point.
Oh,
Now, if they say, oh, on the 7th day, on day 9, we're not going to cover this anymore. This could have been done outpatient. I mean, we hear that.
sure.
Okay, then if you don't feel ready to go, okay,
Mhm.
we're not going to send you home.
I start using the 15
You
days.
start using your prepaid days in our temporary beds, and that's why we've left 3 South the way we have, the 4 Medicare beds and the 6 temporary beds, because that happens. That happens, and that's worked. That's a beautiful plan. It's worked out great. Oh, well, I'm sorry, Chief.
I just, you said it's very stressful. I wanted to share my experience in helping the health and athletes who knew I would need services right after moving in. But I had Medicare Advantage and Jennifer came to see me and said they were gonna stop. I had to go home. It wouldn't serve me anymore. If I'd had a Medicare, it would have continued to cover. She said, well, you should appeal. And I did, and I got approval. She said that never happens. But the point was, it gave me an end to be able to get home. Because here, you're well cared for, and I did have a partner. So it was it was a good thing.
Mhm.
It wasn't a stressful thing. Jennifer was there holding my hand the whole time, and I never felt like I would be abandoned. And she was clear about
Oh, yes, yes. Oh, no, you will never be abandoned. And when I say stressful, that person that lives alone, that doesn't feel like they have their confidence yet, and the insurance company saying, well, we don't know how much longer, we don't know how much longer, that's just about some anxiety for people, and I'm like,
that experience.
yes.
So I have Medicare and you've got 4 Medicare beds. What happens if, when I need to be in a bed, they're full?
So our beds are not often full, but there are 2 things that can happen in that place. So we have a handshake agreement with Hillcrest, with Carol Woods, and with Crosdale, that if you in fact would like to go and use your Medicare days in one of those facilities, as soon as we have a bed open, you're welcome to come to us. Okay. But the other part is, and this is typically what people will do, we know when people are moving out of those beds. Okay. So if we know that in 3 days, Miss Smith is going to be leaving, we're gonna say, of course, we're gonna look at other facilities for you if that's what you wanna do, but you can use 3 of your prepaid days to stay in a temporary bed and move to that Medicare bed as soon as that opens. Yeah, because you have 30 days from discharge to utilize your Medicare. With the Advantage plans, they have to approve that happening. With traditional Medicare, that's just a rule. Mhm. Closed. Closed CON. So the closed certificate of need means because you live here and you purchase to live here, then you have, you are entitled to use the skilled nursing beds. They are not open to anyone outside of the forest. Okay. Our assisted living is not a closed certificate of need. Therefore, we have had, if you've heard the language direct admits, someone has to qualify financially and medically. But when we have census that we need to build up, we are able to evaluate those people. They have to be approved financially. They do pay an entry fee. They do pay the premium of the daily rate. They do not get the deep discounted rate that you all get, the 40% and 60%. They pay, I think it's 98%. It's either 98 or 99% of our per diem. And I think that is 500 something dollars a day. Okay, so that's what that means when you hear people talking about that. Residents are responsible for any deductibles or copays as determined by their coverage they have chosen with their insurance carrier. Okay, let the buyer beware. Medicare Advantage plans. So Medicare Advantage plans, and I don't want to be biased. I'm just going to share the information. Medicare Advantage plans market to a group of people that are typically over 65, but they have a lot of advantage to them if someone is very well. Okay, they have a multitude of benefits that are very, very helpful to you if you are well. Where it gets complex is the very serious micromanagement that is done, which is in direct contrast of Medicare. I'm not saying people shouldn't manage their dollars. Please don't take me wrong about that. I don't mean that at all. But it becomes a very microscopic process for whether that person, and they're reading a medical record. They're not here with you. They're not seeing you. And they're going to make a decision about what's next for you based on what the medical code says should happen for you. So this is a very, very stringent coverage. And again, they will not participate with us in terms of creating contracts where that's concerned. Not saying these plans are good or bad. The key is to understand what you're buying and whether it is right for you. Many insurance companies are promoting zero premiums and lower cost. Does it sound too good to be true? Okay, so this is the structure that I have been speaking of, and this talks about what your coverage looks like when you are skilled nursing or in a Medicare state, which is what I've been describing to you. Okay, so we have 4 rooms. They are on Hickory South, and they are rooms 307, 8, 9, and 10. All right, those are the only 4 rooms we can bill from for Medicare. You would think, oh, you can do 301, 302. You cannot. It was rejected. Okay, those are called Medicare distinct part beds. Those also apply to the Medicare Advantage beds. So the person that the service that is billing you is the person that bills your insurance, is the entity that bills your insurance. If you have an x-ray done, the x-ray company is going to bill your insurance. If you have a visit in the clinic is going to bill your insurance. If you have Duke Lab is going to bill your insurance. Many people are under the impression that I live at the forest, so if I have anything medical done, the forest has billed for all of these services. That's not how that works, because you have to have your own EIN number for specific service that you can bill for. So Karen describes that in a wonderful way. And she said, the person providing the service is the person that bills the insurance. So we provide the service for your Medicare rehab stay, so we're gonna bill the insurance. Okay, that's what all this says. Okay. It's a good rule of thumb. This is explaining again, the person providing that service is the person who is billing it. And that's exactly what this describes. Just because it happened in the clinic or at the health center doesn't mean we billed it. Okay, but that's what this slide's about, exactly what I just said. Okay, so, and I noticed these names haven't been updated, so we need to do that. There are 3 levels of care here. There are 2 specific, forms of care in the assisted living. That is traditional assisted living and memory care. Okay, we have a very specific license for memory care. The folks, must be able to, the concern is that someone is going to get out of the safe space into a space that is unsafe, that they are not supervising, and they're not capable of managing that. So within our assisted living, we have 2 types of service: traditional assisted living and memory care. In skilled nursing, that's all the same. Okay, how do we pick households where people live? We look at someone's social ability. Do they have a friend that lives there? But also, what is the acuity in that household? That's really important, that we have our staff situated in such a way that they're able to meet all of those needs. Okay, so that's what this talks about, is exactly what it means to be a temporary resident, a Medicare resident, or a permanent resident. Okay. All right. What questions do you have for me? And I don't know what time I'm supposed to be through.
When does a long-term insurance, when will long-term insurance pay? The long-term insurance, when is that?
So the long-term care insurance is very interesting. So always talk to your social worker if you have any questions about it. They are constantly changing the fees and trying to help you know that maybe you should increase the amount. We're happy to talk with you about it. We can't tell you what to do, but we can certainly advise you what our costs are, so you can make an informed decision about if you need to take the next, whatever they call it, plateau or whatever. So we're happy to do that. 2 places long-term care can be helpful. It can be helpful in assisted living or skilled nursing. I see that as one for the health center. Or if you're getting very specific hands-on care in your home from the Forest at Home, and that's going to be for a period of time or a long time, then you can certainly work with Takitha on getting your long-term care started there. The keys to long-term care is you must initiate it. They will not talk to us about initiating it. But once it is initiated, we submit all the paperwork that needs to be done. Okay, and we help walk you through that. Yes. And then the other feature to that is if you're in the health center, we're gonna have to send paperwork once a month for you at the end of the month. To say if you've been out of the facility X number of days, because if it's a certain amount, then, you know, they're paying directly to you. If you're in the health center for those 30 days, in the month of April, then they're sending you a check for the daily rate they've agreed to pay you, and then you pay us. Yeah, they don't pay directly. Yes, ma'am.
I right now have an issue with the mobile X-ray. I had gotten, I got a list, my insurance covered, and then there was a amount that wasn't covered. And I sent them a check on May 20th. And yesterday or the day before, I got a bill from them for the same thing. So, and I tried to call to say I paid you, and they don't answer their phones. So I'm not sure to just wait it out, or how should I? I mean, I went to Lori and she said, but so I'm not quite sure. I don't want to send them another check.
No, don't send another check.
So I
What does Laura say?
she was surprised that people usually don't get a billing. This was a very $25.81.
Right.
But evidently that was not covered, but they don't answer their phones. They said, you know, I called billing to tell them I paid you, but just wait.
Was mobile extra?
Mobile X-ray.
Okay, okay. If you get another bill, let us know. It may because the billing is, the turtle. It may just have generated automatically.
No, I paid on May 20th. I have the check.
Oh, yeah. And we can certainly advocate for you with that,
Okay.
if you get that.
I mean, as I said, it's not a tremendous amount, but it's like, it's,
At some point, it's just
it's
the,
great if I.
the principle. It's okay.
I don't want to go to jail.
No, and I don't want to do that.
That's very
Yeah. Anybody else?
Where's your mom?
Yes.
We're afraid of the health center. Folks to be apprehensive about going, which is, I guess, natural. And I just feel like we ought to have some better stories. Like I was there and had such a good experience. I was so grateful. It was amazing. I can't imagine having gotten that care if I was the president.
Mhm.
I would have gone somewhere else. So I just feel like we need some more stories so people can feel comfortable with it.
I agree with you. I had this conversation with Anita yesterday, as a matter of fact, because we were talking about, pros and cons and how you grow. And I said, we have a number of people that have come for a respite stay or a temporary stay. And, things were kind of, so at home, how they were spending so much time being able to show up at the community table. It might take you 3 hours to get there, but when you show up there, oh, she's great, she's fine. It took 3 hours. Because there are limitations there. And people are choosing to stay. We've had 3 or 4 residents in the last 3 months. And they're like, no, this is where I need to be. People are nice to me. And if I have an episode of AFib, they're gonna be right here calling the doctors, helping me get through that. This isn't gonna take me 10 days to recover from because I've tried to navigate the system. This is going to take me 2 days to get through because they just increased the medication. It's called the doctor. So we are talking about what does that story look like, getting that story out. Are we perfect? No, we're not
But
perfect.
it's more than that. And I'm not, my example is assisted living when people are go there permanently. It's set up family wise. I mean, and that part, I've had friends visit and they're like so impressed.
Yes. Yeah.
With it.
The article that was in the Forester about Diane Strauss
Yes.
was amazing.
Yeah.
Well, I have another good story. This all helped me make the decision to move here. So I had a friend who had a red, her father was arrested and in hospice. And my friend Debbie was a hospice volunteer at one point. So when she was talking to the hospice nurse, she kind of talked a little bit more about the care. And the hospice nurse said that when she comes to the forest, that the staff here immediately collaborate with her. How can we be helpful? She says she doesn't get that anywhere else. She said the forest is the best place. And to hear that from a hospice nurse, that was really impressive. So that was another little benefit to coming here. In the checkbox, should we do this?
We don't have to write your story, I'm sure. But getting that narrative out there, it's always easy to take that stuff that doesn't sound so great and just, with it. But what are we doing with that good information? Katie Lewis was telling me, the artist in residence, about the men's group that she started and what happened yesterday. And she said, who suggested that to me? And she told me the gentleman's name and I was like, really? And she was like, I said, I'm thrilled about that. So these things getting out, our activities team is phenomenal. Our team is phenomenal. I mean, they are doing things 24/7. And I think getting that out is really, really important. But some of that fear is, gosh, I'm moving for the last time, and I'm so different, and I always hear getting old's not for sissies, I always hear that. And one gentleman told me one time, he said, you need to put getting old's not for sissies right there on your arm. I was like, oh no, I don't think so. But it's a difficult time. It's a difficult time when you're not just there for rehab and back. Yes, sir.
I know you, about the Medicare Advantage. And a rule of thumb, how easy is it to get to backtrack, go away from the Medicare? Go back to the.
Yeah, so the enrollment opens in December every year. And you make the phone call to 1-800 Medicare and say, I want to make a change.
Easy,
Mhm.
easy breezy.
You wait your turn on the phone, but yeah.
There's a big problem with going back from an Advantage plan to regular Medicaid. Is you may not be able to buy the gap insurance.
The B, the B insurance.
So supplemental, plan. And the reason I went to Medicare Advantage is when I retired, my company gave me,
I'm not here, baby.
no, that gap policy that makes the, covered most of the 20%.
Yeah.
Along the way, 3 years ago, they decided to discontinue it because the company was bought by another company. And so I had chose Medicare Advantage. It's saving me almost $5,000 a year for the gap policy would have cost. And my deductible was only $3,500, so I have to eat $3,500 when I come to be one of your customers. But after that.
We're gonna be advocating for you anyway,
I know
in
you.
any way we can.
But that's the problem, is once you have left Medicare and gone to an Advantage plan, it's close to impossible, but you can go back to Medicare, but you may not have something to cover that 20% that Medicare doesn't cover. That's
That's good information.
Yeah.
That's good information. All right, I don't know what time it is.
You haven't told me, but
Oh,
if you're ready to.
oh, I'll do whatever you want.
As long as we don't miss lunch.
Oh, I know, I don't let that happen. Is that good? Is that helpful?
Very.
Okay, I have my cards. I'm happy to entertain questions of any sort. Shape, form, fashion, tell me about your weekend, whatever. Anybody care to start? You know how I'm. You want? You know how I'm. You know. Anybody have?
Just leave it in the front. and people can-
Okay. Thank you. Yeah, if we found out we need more, let me know.
Thank you, I'll give them to you. if we don't use.
Well, no, it's, I think I'm on every website we have or something.
Thank you.
Oh, of course. Yeah, oh, my pleasure. My pleasure. Happy to have you.
Can I ask you a question? I was going to your level, and if you ask you questions, because I need to like this. That's
What happened?
Okay, I think everybody else.
Okay. I am Eleanor. I did hear this.
Thank you.
Yes. I have lots of different offers for different. I have sessions. But
Yeah, they have.
They have a lot of.
Of course.
My.
Like we do.